Welcome to today's video lecture. Today, we're going to delve into a fascinating topic, cholecystitis. Before we start, don't forget to check out our website madeformedical.com for hundreds of more videos like this at the end of this video. The link is in the description. In this session, we will delve into the intricacies of cholecystitis, including its etiology, pathophysiology, clinical presentation, diagnostic approaches, and management strategies. By the end of this lecture, you will have a comprehensive understanding of cholecystitis and its impact on patient care. So, let's begin. Cholecystitis is an inflammatory condition affecting the gallbladder. It is commonly caused by the presence of gallstones, which obstruct the bile ducts and lead to the accumulation of bile within the gallbladder. This accumulation causes irritation and inflammation of the gallbladder wall. There are two main types of cholecystitis: acute cholecystitis and chronic cholecystitis. Acute cholecystitis is characterized by a sudden onset of symptoms and is usually associated with the presence of gallstones. Chronic cholecystitis, on the other hand, is a long-term condition marked by recurrent episodes of inflammation and may or may not involve gallstones. Understanding the pathophysiology of cholecystitis is important to accurately diagnose and manage the condition. The pathophysiology involves a series of events that lead to gallbladder inflammation. The primary contributing factor is the obstruction of the cystic duct, which is the duct that connects the gallbladder to the common bile duct. This obstruction can occur due to the presence of gallstones or other factors, such as a tumor or biliary sludge. When the cystic duct becomes blocked, bile cannot flow out of the gallbladder, leading to distension and increased pressure within the gallbladder. This distension causes ischemia or reduced blood supply to the gallbladder wall, leading to tissue damage and inflammation. The obstruction also disrupts the normal flow of bile, which is responsible for the digestion and absorption of dietary fats. The stagnant bile within the gallbladder can become concentrated, leading to the formation of gallstones. Gallstones can further obstruct the cystic duct and exacerbate the inflammation and ischemia in the gallbladder. As inflammation progresses, various inflammatory mediators, such as cytokines and leukotrienes, are released, further contributing to tissue damage and the recruitment of immune cells. The inflammatory response can extend beyond the gallbladder, affecting the surrounding tissues and potentially causing complications such as abscess formation, perforation, or the development of gallbladder empyema, pus-filled gallbladder, as in this picture where you can see gallbladder is completely filled with pus and pigment stones. Overall, the pathophysiology of cholecystitis involves the obstruction of the cystic duct, leading to gallbladder distension, ischemia, and subsequent inflammation. The presence of gallstones, impaired bile flow, and inflammatory mediators contribute to the progression of cholecystitis. The clinical presentation of cholecystitis can vary, but the most common symptom is severe abdominal pain, typically in the right upper quadrant. The pain is often described as steady, intense, and may radiate to the back or right shoulder. It is commonly triggered or worsened by eating fatty or greasy foods. The pain can persist for several hours and may be associated with tenderness and guarding upon palpation of the abdomen. Other symptoms commonly seen in cholecystitis include nausea and vomiting. Patients often experience episodes of nausea and may vomit, especially after eating a fatty meal. Fever and jaundice. Inflammatory processes within the gallbladder can lead to an elevation in body temperature, resulting in fever and chills. In some cases, cholecystitis may cause obstruction of the common bile duct, resulting in the backup of bile and subsequent yellowing of the skin and eyes called jaundice. Abdominal distension. The inflamed gallbladder can lead to abdominal bloating and distension. Murphy's sign. This is a physical examination finding where there is tenderness in the right upper quadrant upon deep inspiration, as the inflamed gallbladder comes into contact with the examining hand. Diagnosing cholecystitis involves a combination of clinical evaluation, medical history review, and diagnostic tests. Here are the key aspects of diagnosing cholecystitis: clinical medical history and physical examination. Begin by obtaining a detailed medical history from the patient, including their symptoms, duration of pain, and any factors that worsen or alleviate the pain, such as food intake. Assessing the patient's medical history may also help identify risk factors for cholecystitis, such as a history of gallstones or previous episodes of biliary colic. Perform a thorough physical examination, paying specific attention to the abdomen. Palpate the abdomen for tenderness and assess for any signs of abdominal distension, guarding, or Murphy's sign, which is tenderness over the gallbladder upon deep inspiration. Laboratory testing: order specific laboratory tests to aid in the diagnosis of cholecystitis. These may include liver function tests. LFT can help assess liver function and identify any liver or bile duct abnormalities. Elevations in liver enzymes, for example. Alanine transaminase, a LT, aspartate transaminase, a ST, alkaline phosphatase, and bilirubin levels may suggest the presence of gallstones or associated complications. Complete blood count. CBC may reveal elevated white blood cell count, suggesting an inflammatory response or infection. Amylase and lipase. To rule out pancreatitis, as it can present with similar symptoms. Imaging studies. Ultrasound. Abdominal ultrasound is the primary imaging modality for diagnosing cholecystitis. It can detect the presence of gallstones, assess gallbladder wall thickness, and evaluate for complications such as gallbladder inflammation or dilated bile ducts. Computed tomography scan. A CT scan may be performed in cases where additional information is needed or when complications such as cholecystitis or pancreatitis are suspected. HEDA scan, cholecystography. This test involves injecting a radioactive tracer that is taken up by the liver and excreted into the bile. It can assess the functioning of the gallbladder and the presence of obstruction or impaired bile flow. In some cases, additional diagnostic procedures may be required, such as endoscopic retrograde cholangiopancreatography, ERCP, or magnetic resonance cholangiopancreatography, MRCP, to further evaluate the biliary system and identify any underlying abnormalities. The treatment of cholecystitis depends on various factors such as the presence of symptoms, the size and number of gallstones, and the risk of complications. Here are the key treatment approaches for cholecystitis. Non-surgical management, NPO, and fluid resuscitation. In the acute phase, patients are typically advised to withhold oral intake, NPO, to rest the gallbladder. Intravenous fluids may be administered to maintain hydration and correct any electrolyte imbalances. Pain management. Analgesics such as nonsteroidal anti-inflammatory drugs, NSAIDs, or opioids may be prescribed to alleviate pain and discomfort. Antibiotics. If there are signs of infection or if the patient's condition is severe, broad-spectrum antibiotics may be administered to target the causative bacteria. Antibiotic choice should be guided by local guidelines and individual patient factors. Symptomatic management. For patients experiencing biliary colic, like intermittent and severe pain, management focuses on providing symptomatic relief during episodes of pain. This typically involves the administration of analgesics, such as nonsteroidal anti-inflammatory drugs, NSAIDs, or opioids as needed. Surgical intervention. The most definitive treatment for cholecystitis is surgical removal of the gallbladder, known as cholecystectomy. This approach is often recommended for patients with symptomatic gallstones or those at higher risk of complications. It can either be open or laparoscopic cholecystectomy. Laparoscopic cholecystectomy is a minimally invasive procedure that involves the removal of the gallbladder using small incisions and specialized instruments called laparoscopy. It is the most minimally invasive procedure, as can be seen in the picture of a patient who had a laparoscopic cholecystectomy. Open cholecystectomy. In certain situations, such as when laparoscopic cholecystectomy is not feasible, an open surgical approach may be necessary. In cases of uncomplicated acute cholecystitis, early cholecystectomy within 72 hours of symptom onset is generally preferred. However, in high-risk patients or those with severe illness, delayed surgery after the acute episode is resolved may be considered. Percutaneous cholecystostomy. In some cases where surgery is not immediately feasible or in patients who are not surgical candidates, a percutaneous cholecystostomy tube may be inserted to drain the infected gallbladder and provide symptomatic relief. In conclusion, cholecystitis is an inflammatory condition of the gallbladder, most commonly caused by gallstones. Prompt diagnosis, appropriate management strategies, and preventive measures are essential in providing optimal care to patients with cholecystitis. And that brings us to the end of our today's video. I hope you found the information helpful and informative. If you enjoyed this video, don't forget to give it a thumbs up, and don't forget to sign up for a premium membership on our website, madeformedical.com, for more content like this.